discuss the PYQ session of the pathology. Okay, so I am going to discuss important questions that were there in your exams few years back. Okay, so these questions are not the exact question what you got in your exams because they are the memory based questions, but most of are the as such that you got in your exams. So let's see what type of questions, what will be the pattern of the questions, okay, and how other questions will be there from the questions which we got in the recent years. Okay, so let's start. So first question is, a patient has been diagnosed with a solid cancer of the bowel. He also experienced massive proteinuria after a few months of initial diagnosis of cancer. Which of the following is likely cause for the development of urinary fibrosis? Okay, and the options are like focal segmental glomerulosclerosis, minimal change disease, membranous glomerulopathy, and membranoproliferative glomerulonephritis. So, what is the answer? So, I think most of the students must be knowing that the answer is here. It's a very simple thing. The answer is option C, that is, it's a membranous. Okay, so let's see why only membranous, not others. So, what is the concept here? Why the question is being asked about? The question is basically about the concept that the membranous, the membranous glomerulonephritis is the most common glomerulonephritis or nephrotic syndrome that is associated with cancers. Okay, so this is the very important thing. You all have to remember this thing, that which type of nephrotic syndrome or the glomerulonephritis is most commonly associated with the cancers like breast carcinoma, lung carcinoma, or any other type of carcinoma. The answer would be it's a membranous. So the most commonly associated nephrotic syndrome with the cancers is the membranes. It's also so many times you will get questions on the most common nephrotic syndrome associated with infections. Infections. That is also the same answer. The same answer will be there. Like if any malarial infection is there or the cystosoma infection is there, then what type of nephrotic syndrome will be there after the infection? The answer will be the similar, the membranous. One more common association with the membranous is it's the most common nephrotic syndrome associated with renal vein thrombosis, RVT, renal vein thrombosis. So, which is the most common type of nephrotic syndrome that is associated with the thrombotic condition, specifically renal vein thrombosis, that is our membranous. So, this is the concept that I want to tell you in this question. Okay. Okay. In which conditions FSGS is common? Like this, the question is there. Then what other type of questions can be there? The conditions where you will see the association with the this FSGS. So focal segmental glomerulosclerosis, FSGS. FSGS is commonly associated with, specifically whenever the questions are given about the any kind of renal operation, like patient is having some kind of renal tumor and there is a partial nephrectomy being done, and in the remaining kidney, if after certain years patient present with the nephrotic range proteinuria, then what kind of pathology is there? That kind of pathology will be FSGS. So after renal resection, renal resection, like in renal tumors, This is one of the very common associations that you have to keep in your mind, that whenever they will ask the questions based on the renal operation, renal surgery, or renal resection, partial renal resection after some kind of renal tumor, and in the remaining kidney, if there is a proteinuria, then a massive range proteinuria should be there, because nephrotic syndrome, what kind of proteinuria will be there? It would be massive proteinuria, more than 3.5 gram. Okay, always remember that when the nephrotic syndrome is considered in your questions, if they will give you the the directly they will give you that there is a nephrotic syndrome, that's the possibility. Second possibility might be there, that they will not be giving you directly the nephrotic syndrome word, but they will give you the proteinuria, that is more than 3.5 gram per deciliter per 24 hour. That is again a direct indirect way to ask you about the nephrotic syndrome. So in questions, always see what is the the type of the proteinuria, how much proteinuria is there. If it is more than 3.5 gram, that means they want to give you the clue that it's a nephrotic range proteinuria. So like this question was there in exams again, like they asked the question that there is a 20-year-old male who is suffering from the renal tumor present at the one of the poles of the kidney, and patient went for a partial renal resection for the tumor, and after certain years now patient is presenting with a proteinuria of 4 gram per deciliter. Then what is the type of pathology there in that kidney? So the answer was it's a FSGS, because patient went for the renal resection. Okay. Even if they will ask you about the HIV infection particularly, then always think about the FSGS, because HIV is commonly associated with the FSGS. Even if they will ask you about the Hodgkin's disease, that is again the FSGS. So Hodgkin is associated with the FSGS, HIV is associated with the FSGS, and heroin abuse. Heroin abuse. So there are three H for you. First H, HIV, second H, Hodgkin's, and third H for the heroin abuse. Okay. So after renal resection, which type of nephrotic syndrome will be there? That will be the FSGS. After the cancers, which is the common type of nephrotic syndrome, the answer will be membranous. After infections, particularly they are not giving you any kind of infection, just they are asking that after infections, which type of nephrotic syndrome will be common, the answer would be membranous. But if particularly asked that after HIV, which is the common one, then you will say it's a FSGS. Even in HIV, here also they are having a particularly important kind of FSGS, that is also called as collapsing type of FSGS. So please remember, this is very, very important question, that which type of FSGS will be seen in HIV patient? The answer will be collapsing type of FSGS. And this question has been there in so many exams. In last 5 to 7 years exams, I have seen this question 2 to 3 times. Okay. So please be aware that which type of FSGS is associated with HIV cases. The answer would be collapsing type of FSGS. And one more important thing, it's the having the worst prognosis out of all the types of FSGS, which is having the worst prognosis, that is the HIV associated FSGS is going to have the worst prognosis. Okay. One word for MPGN. In which conditions MPGN is commonly seen? Okay. So like hepatitis B, hepatitis C. Okay, after these infections, particularly you will see the more cases of MPGN. If they will not giving you the particular type of infection, they are giving you the questions that after infection, which is the common one, the answer will be membranous. Okay. If they will give you the particular infection like HIV, then your answer will be FSGs. Okay. If they are giving you particular question about hepatitis B and C, then your answer would be MPGN. Okay. MPGN is one more condition where MPGN is commonly seen, that is called as lipodystrophy. So this is again an important condition which is associated with the MPGN. Okay, so these are the few important secondary causes. What they are called as? They are called as secondary causes. Primary means you don't know the cause, exact cause of the condition. Like most of the nephrotic syndromes will be idiopathic in nature. But sometimes you will get the answer that why there is a nephrotic syndrome. Like MPGN will be there due to the hepatitis B, C, and lipodystrophy cases. FSGS can be there in any individual due to the secondary causes like HIV, Hodgkin's, heroin abuse, or after some kind of renal surgery. And membranous will be commonly seen after the cases of cancers, like the solid cancers of the organs like lung cancers, or the breast cancer after infections. And renal vein thrombosis is quite commonly seen in which conditions? That is the membranous. Okay, I think this is important for you. So that's why I told you these all important concepts in one question. And this was the question which was asked in 2000, I think 18 or 17. So let's see the next question. The next question is from the general pathology. The question is which of the following contributes to immortality of the cancer cells? So this is the question based on the cancer pathology. So options are like option A, topoisomerase, option B, telomerase, option C, RNA polymerase, and option D, the helicase. The one thing which is common about all the options is that they are belonging to a enzyme category. So there must be some enzyme which is responsible for this immortality of the cancer cells. Okay. So answer is, what is the answer? What is the correct answer? The correct answer is telomerase. Okay. So now the question is why telomerase only? What is the difference between the telomerase and the telomeres? What is telomere? How telomere is related with the immortality or the mortality of the cell? And why only cancer cells are immortal? Why our normal cells are not immortal? Our all cells are mortals. That's why we are mortal. We are going to die one day. Why we are going to die one day? Why not the cancer cells are going to die one day? Why they keep proliferating for their whole life? Okay, so that's very very important. Even if the cancer cells are of our own body, then also they are different from our normal cells because they are immortal. They never stop their proliferation. Every cell can count its proliferation. God has given every cell the exact type of the time when they can divide itself. Okay, like some cells can divide itself up to the 80 times, some cells can divide it up to the 100 times, but not more than that. So why there is a exact count and how cell can count their division? That is important. Okay, so let's see. I'll tell you the concept here. The concept is that every one cell, like this is the first cell, it will divide and it will divides into two daughter cells. Okay, again this cell will divides by mitosis and again it will give rise to two cells. Okay, again this cell will divide and this cell will divide into two cells. Okay, but after some divisions now there will be no further division, no further division. So there will be no further cell division. Okay, now the cells are able to count their division. So how this is possible? How cell can count that I have to divide 3 times, 4 times, or 10 times? It's important because after every cell division, like this is the first cell, this is the length of its DNA. This is the length of its DNA, and at the ends of the DNA, there are certain repetitive nucleotide sequence. Like these are the repetitive nucleotide sequence that are present at the ends of the every DNA. For example, I'm taking like cytosine is there. Okay, it can be guanine, it can be any other thing also. So like there is a repetitive nucleotide sequence for cytosine present at the ends of the DNA. Okay, like if it is 6 cytosine here and 6 cytosine here. Okay, after every successive cell division, the ends are getting shortened. Ends are getting shortened. Like in the next cell division, there are only 4 repetitive nucleotide sequence are remaining. After next phase, only 2 nucleotide are there present at the end of the cell. And after this division, there are no nucleotides present at the ends of the DNA. What are these ends called as? What are these repetitive nucleotide sequence called as? They are called as telomeres. Telomeres. So repetitive nucleotide sequence present at the ends of the DNA, they are called as telomere. And after every successive cell division, our DNA length is getting shortened. Specifically, the length of the telomeres are getting shortened. And after reaching a critical length, this is called as critical length of telomeres. There will be no further cell division. There will be no further cell division. And this is called as cellular senescence. Cellular senescence. Cellular senescence or cell aging is there. Okay. So this cellular senescence or cell aging is there. 1 minute. Okay. Cellular senescence is there. So senescence or the aging will be seen in a normal individual or normal cells, but not in the malignant cells. So why there is discrepancy? Why the telomeres of cancer cells are not getting shortened? Okay, because they are having one very important enzyme that is called as telomerase. What is telomerase? Telomerase is what? What is telomerase? What it is doing? It is giving some kind of nucleotide to the DNA at the end of the cell division every time so that the length will be maintained again. So again, it will be giving the new nucleotide to the ends of the DNA. So after every successive division, the length of the telomere will be maintained by the presence of telomerase enzyme. The question which comes in our mind, then why we cannot have the same functioning? Because in normal adult individual, we are not having any telomerase activity. Okay, so remember, telomerase activity is not there in somatic cells. Telomerase activity will there be only in the malignant cells because malignant cells can reactivate their telomerase. So remember, malignant cells can reactivate their telomerase, while normal cells do not have normal cells do not have telomerase activity at all. 0% activity. So is there any normal cell in our body which is having the telomerase activity? Anybody knows that which cells in our body having the telomerase activity and they are also immortal? If being the normal cell, they are the germ cells of our body. So only the cells in our body which are normal but they are immortal and they are germ cells. So they have 100% telomerase throughout our life. So, which cells in our body never stop their proliferation? Those are the germ cells that are present in our gonads. So, germ cells never stop their proliferation. That's why we can give rise to birth to a baby because we are having the germ cells which keep replicating for throughout their life. So, those are called as germ cells. Okay. So, germ cells have the highest telomerase activity in normal cell biology. Normal adult somatic cells are not having any telomerase activity, while cancer cells can reactivate their telomerase activity. So that's why they become the immortal. So once in exam, they ask the question that what is happening to the telomere length after every successive cell division. Option A, telomere length remain constant. Option B, telomere length will be increasing. Option C, telomere length is getting shortened. Option D, all of the above. So answer was the C, the telomere length is getting shortened after every successive cell division. So now you got the point why we all are going to die, why there is not an immortality, why there is the mortal truth is the biggest truth of the world, because we are not having the telomerase enzyme. And the cancer cells can have the property that they can reactivate their telomerase and they become immortal. So that's why the aging is there. Okay. So I think this is a very, very important question, very important concept also. So please remember this thing. It's a very, very important thing. Okay. So let's see the next question. Next question, I think it's the simpler one. A patient presents with the presence of the thyroid swelling and the weight loss, the physician found the presence of the cervical lymphadenopathy. So one of the very important sign here is the cervical lymphadenopathy and thyroid swelling itself. Okay. Patient went for the thyroid biopsy. Histopathology report of the patient suggested the presence of orphan ani nuclei. So this is one of the very important clue and very important histopathological finding, and which is already a diagnostic point. Even if they are not giving you the picture, even if you're not able to understand the picture, that's not the problem, because you can easily make out the diagnosis by this finding orphan ani nuclei. That is, I think everybody be aware that it's a papillary carcinoma thyroid. So answer is papillary carcinoma thyroid. That is the option C. So papillary thyroid cancer, medullary thyroid cancer, anaplastic thyroid, and follicular. Out of these, orphan-NEI nuclei is only and only classically seen in the papillary carcinoma thyroid. So what is orphan-NEI nuclei? It's a nuclear clearing. It's a very simple thing. It's a nuclear clearing or clear nucleus. Like you can see here, all the nucleus here, if I'll magnify this picture, then you can see clearly that every nucleus here is not getting any stain here. Like here in this picture, you can see that the nucleus is looking empty. It's looking clear. So this is optically cleared nuclei that is called as orphan NEI. Orphan NEI word is used because of the cartoon character. There was an American program that is called as Orphan Annie, and the eyes of this Orphan Annie cartoon character are cleared from the center. So from here we got the word orphan any nuclei. Okay, so this is one of the very, very important thing, orphan any I nuclei. And the nuclear features of the papillary carcinoma thyroid are very important. So like nuclear clearing is being asked in your exams, then they can also ask you nuclear grooves. Grooves are also seen in this condition. Nuclear folding is also seen. Nuclear folding is also seen in the condition. Nucleus become fold like this. Like this, you will see nuclear grooves or folds. Both are the same things. Nuclear grooves or folds are the same thing. Okay. Sometimes you can see the intranuclear inclusions. Intranuclear inclusions. So within the nucleus, you can see sometimes the inclusion like this. So those will be called as intranuclear inclusions. Like this, you can see the intranuclear inclusions. So all these are the important findings of the papillary carcinoma thyroid. One more thing about the papillary carcinoma thyroid, that it is associated with the radiation. So which thyroid cancer is associated with the radiation exposure? That is the papillary carcinoma thyroid. Okay. One more important question which is usually asked about the medullary carcinoma thyroid, that is the presence of one very important thing that is called as amyloid. So in which type of thyroid cancer the amyloid deposition is seen? That is the medullary carcinoma thyroid. Which mutation is commonly associated with the medullary carcinoma thyroid? That is RET gene. That is also one of the very important questions. Which syndrome is associated with the medullary carcinoma thyroid? That is the MAN2 syndrome. That is also one of the very important questions. Which is the tumor marker of the medullary carcinoma? That is also important. That is calcitonin. So All these questions are very, very important about the thyroid carcinomas or thyroid malignancies. Okay, one more important thing about the papillary carcinoma thyroid, and that is the presence of specific type of calcification that is not seen in every cancer, that is seen in particularly very few cancers, and that is called as pseudomatous calcification. Calcification of pneumoma bodies. So they are also called as pneumoma bodies or pseudomatous calcification. So both are the same. There is no problem. So please remember very important questions about the papillary carcinoma, medullary carcinoma. Papillary carcinoma, the one of the very important question is the histopathology itself. Orphan NEI nuclei, nuclear grooves, nuclear foldings, intranuclear inclusions, pseudomatous calcification. All these are important questions about the papillary carcinoma thyroid. Which thyroid carcinoma is associated with the radiation exposure? That is again the papillary carcinoma thyroid. Okay, which is the most common solid cancer associated with the radiation exposure? That is again the papillary carcinoma thyroid. Okay, and few important points about the medullary, that is it is having the amyloid deposition that is not seen in any other type of the thyroid cancer. It is associated with the RET gene mutation, that is again important. Man2 syndrome association, that is also important. And the tumor itself releases huge amount of the calcitonin. So serum calcitonin levels will be high in which thyroid cancer? That is the medullary carcinoma. Or calcitonin is also acting like one of the very important tumor marker for which thyroid malignancy? That is again the medullary carcinoma thyroid. I think these are the important things you must be knowing about the thyroid cancer. Thyroid cancer are one of the very important cancers. They are very common cancers. Okay, so that's why these questions are particularly commonly asked in your exams. Let's see the next question. A patient present question number 4. A patient presented with the development of the seizure for which the CT guided biopsy was done. The histopathology revealed the again one the same thing that I told you in the last question. That is the pneumoma bodies. What are pneumoma bodies? They are nothing. They are the calcification. What kind of calcification they are having? They are having the basophilic, like blue in color calcification, and this will be in this manner. So you will see going to see the calcification in this kind of pattern, that is called as pseudomatous calcification. So these are the concentric concentric lamellated calcification. Which type of calcification it is? Is it a dystrophic calcification or is it a metastatic calcification? So I always remember, any kind of calcification which is happening in our body, they are of two types. Either they can be of dystrophic or the metastatic type. So this is this pseudomatous calcification belongs to the category of dystrophic calcification. Dystrophic calcification. Okay. So in which conditions dystrophic calcifications are commonly seen? Dystrophic calcifications are commonly seen in dead, degenerated, or damaged tissue. Dead, degenerated, or damaged tissue. And commonly in these conditions, serum calcium remain normal. So always remember that serum calcium remains normal in which type of calcification? Those are called as dystrophic calcification. Okay. So what is pneumoma bodies? Pneumoma bodies are the type of the dystrophic calcification only. So why the name is given to these calcification? Why they are not uh, called as only and only dystrophic? Why they are called as pseudomatous? Because they have the specific pattern of deposition. Like they will be having a concentric, lamellated, these kind of depositions. So that is particularly seen in only and only in the pseudomatous calcification. So pseudomatous calcification will be seen in which type of the brain tumor? The question is that one. Answer is meningioma. So always remember, there are certain tumors where you are going to see the pseudomatous calcification. I'm telling you the pseudomatous calcification where they are seen. Pneumoma bodies or pseudomatous calcification seen in certain tumors only. What tumors? Like meningioma of the brain, then there will be serous cyst adenocarcinoma. cyst, adenocarcinoma, ovary. There can be mesotheliomas of the coelom, of the peritoneal cavity, pericardial cavity, or pleural cavity. Mesotheliomas are also having the similar kind of calcification. Okay. There can be a papillary carcinoma thyroid. That why I told you this thing in papillary carcinoma thyroid also. So meningioma, serous cyst adenocarcinoma ovary, mesothelioma, and papillary carcinoma thyroid. So these are the few important tumors where you can see these concentric lamellated calcifications that are called as the Samoma bodies. What type of calcification it is? It is a dystrophic kind of calcification. What is the relation with the serum calcium? Serum calcium here remains normal. What is the another type of calcification? Besides this dystrophic, the another type of calcification are called as metastatic calcifications. Metastatic calcifications are seen in which conditions? In normal, healthy the tissue, the calcification is called as metastatic calcification. And here in all the metastatic calcification condition, you will see that the serum calcium remain elevated. So these are the hypercalcemia condition. So how you will remember that what are the the conditions where you are going to see the metastatic calcification? Very simple. You have to remember the causes of the hypercalcemia. If you remember the cause of the hypercalcemia, then it's become very easy to remember that what will be the conditions where we can see the metastatic calcification. Like metastatic calcification can be seen in CRF, that is chronic renal failure, because chronic renal failure cases are associated with the hypercalcemia. Like sarcoidosis is also one of the cause of the hypercalcemia. So here you can see one of the most common cause of the hypercalcemia in the world is hyperparathyroidism. Hyperparathyroidism. So here also you are going to get the hypercalcemia. Milk alkali syndrome, that is also one of the very important condition where hypercalcemia is seen. Then there can be a metastasis to bone. So when be any cancer is metastasizing to bone, the the bone is going to dissolve due to the metastasis, and the bone calcium will be leaked into the blood, and it will lead to hypercalcemia. Okay, which cancers can metastasize to bone most commonly? Like lung cancer, breast cancer, even thyroid cancers very commonly spreads to brain. So these are the common cancers which leads to osteolytic lesions in the bone, and osteolysis will produce the lysis of the bony calcium, and that calcium is going to leak into the blood, and it will get deposited in the other organs in form of metastatic calcification. Okay, now the last question about the calcification. Tell me the stain, which is the special stain used for calcification. The special stain used for the calcification is von Cosa. And one more thing, that is Alzarin red. Okay, so I think now you must be aware that von Cosa is one of the very commonly asked spatial stain, and most of the time this question is being there in your exams about the spatial stain. So that's why von Cosa has to be remembered by you. Okay, even if you do not want to remember Alzarin red, no problem. But von Cosa has to be kept in your mind because it is very commonly asked spatial stain. Okay, let's see the next question. So the last question was about the calcification, their stain, what are the types of the calcification, what are the special type of the calcification, what are the tumors where we are going to get the semomatous calcification or semoma bodies. Okay, let's see the next question. A old man underwent a bone marrow examination which revealed the presence of finding shown in the image. What is the most likely diagnosis that is there? Okay, so this is the picture given to you. I think this is a straightforward question. There is no problem about the thing. The picture itself is a self-explanatory. Okay, it's a very good picture. Okay, in most of the cells which are given to you in the bone marrow, you can see that in most of the cells there is a perinuclear halo. Here you can see the clear area around the nucleus. Here also in this cell also you can see a clear area around the nucleus. Just near to the nucleus there is a clear area. What is this thing? Second thing, in every cell you can see that nucleus has been pushed to the periphery of the cell. You can see there is no centrally placed nucleus. In every cell you can see that nucleus is pushed to the periphery of the cell or the periphery of the cytoplasm. So nucleus is eccentric in every of these cells. So only these two features of the cell can give you the clue that what are these cells. So eccentric nucleus, eccentric nucleus, and perinuclear halo, perinuclear halo or clearing. So now answer the question. What kind of malignancy it could be? Is it a multiple myeloma? Is it an acute lymphoblastic leukemia? Is it a tuberculosis or is it a sickle cell? Sickle cell I can easily rule out because there are no sickled cells. Sickle cells are like this. Okay. So with the pointed ends, the sickle shaped cells are called as sickle cell anemia cases. Tuberculosis, you are going to see the granuloma. In the tuberculosis, they will always give you the picture of the granuloma. So this is not the granuloma. In the granuloma, what kind of cells you are going to see? We are going to see the sleeper shaped cells like this. We are going to see the sleeper shaped cells collection. That is not the condition here. So tuberculosis is again ruled out. Now we are confused between two conditions, ALL and multiple myeloma. In ALL, what you are going to get? In ALL, we are going to see the blast cells. In ALL, we are going to see the blast cells, which will be having a prominent nucleoli. Okay. So blast cells will be the round cells, which will be having a centrally placed nucleus. So important is what? The centrally placed nucleus. So it's not eccentric. In which condition? Multiple myeloma. What is the multiple myeloma? It's a plasma cell malignancy. It's a plasma cell malignancy. And here you are going to see the plasma cells. What are the plasma cells? Plasma cells are the cells which are having a eccentric nucleus like this that is not present in the center of the nucleus, and around the nucleus you are going to see a clear area, or there will be a halo around the nucleus, perinuclear halo. That is very very important about the plasma cell morphology. So that's why the answer here is multiple myeloma. Okay, so what is multiple myeloma? It's a plasma cell malignancy. So I think it's clear, very important, that it's a plasma cell malignancy, that is called as multiple myeloma. Which is the most important interleukin of the plasma cells? Because plasma cells are proliferating here. So which is the important interleukin? IL-6. Okay. IL-6 will be doing what here in this plasma cell pathology? IL-6 can activate the osteoclast. IL-6 can activate the osteoclast activation. Just in few words, I'll brief the multiple myeloma pathology for you so that you can uh, be very easily going to solve the questions about the multiple myeloma or plasma cell malignancy. So, which is the most important interleukin of the plasma cell malignancy? IL-6. What IL-6 is doing here? IL-6 is going to activate the osteoclast. What osteoclasts are going to do here? Osteoclasts having the same action everywhere. So, they are going to dissolve the bone. They are going to dissolve the bone, dissolve the bone. So they are going to produce the osteolytic lesions, punched out osteolytic lesions in the bone. Question is, which bones are most commonly affected in the multiple myeloma? The most common are the vertebra. That's why patient most of the time have the low backache during the cases of multiple myeloma diagnosis. The one of the most common finding is low backache. Why? Because there is a vertebral bone osteolysis. Sometimes it can lead to the compression fracture of the vertebra. Okay, because of the vertebral weakness. Then it can also lead to ribs osteolysis. It can also lead to osteolysis in the skull bone. So these are the things. Osteolysis leads to what? That I told you earlier also. Osteolysis leads to dissolving the bone calcium into the blood. That is called as hypercalcemia. Hypercalcemia. What hypercalcemia is going to do? Hypercalcemia, the calcium is going to deposit in kidney. So kidney defect will be there due to calcium deposition in calcification in the kidneys. So this is the pathology of plasma cell malignancy. Why there is osteolytic lesions in the plasma cell malignancy? Because the IL-6 can activate the osteoclast, and osteoclasts are going to dissolve the bone by producing osteolysis. Why there is hypercalcemia in the multiple myeloma? Because of the osteolytic lesions in the bones. Which bones are commonly affected in the multiple myeloma? The vertebra, ribs, skulls, these are the bones which are commonly involved. What is the problem with the plasma cells? If they are proliferating, why they are not good for us? Because normally plasma cells usually produces the antibodies like immunoglobulins. The plasma cells are going to produce. So here, if they are abnormal, also they are going to produce the immunoglobulins. But these kind of immunoglobulins which are produced by the malignant plasma cells are dysfunctional. They are not good for us. Even if the huge amount of immunoglobulin is there, but still we become immunodeficient in this condition. Why? Because these immunoglobulins are not helping us for fighting with the infection. So these are the dysfunctional or bad immunoglobulins. So plasma cell are going to proliferate. What they are going to produce here? Immunoglobulins. So huge amount of immunoglobulins are going to be released into the blood. Okay, and these immunoglobulins are going to be deposited in the various organs with the help of the blood. So that's why here also kidney dysfunction will be there. So kidney dysfunction, there are the two important cause. First cause is immunoglobulin itself are getting deposited. That's why kidney become dysfunctional. Second thing, hypercalcemia itself can produce the kidney dysfunction. Okay, so that is important about the plasma cell malignancy. Okay, again, I'm telling you, plasma cell malignancy is one of the most common malignancies that are there in your exams. Every year, you will get one question based on the plasma cell malignancy, multiple myeloma. So please remember that you have to read thoroughly the plasma cell malignancy. So many questions are there. Why hypercalcemia is there? Why there is kidney dysfunction? Why there is osteolysis? What is the role of IL-6, which is the most common interleukin that is belonging to the plasma cell malignancy? Okay, what is the CRAB criteria? So homework for you is CRAB criteria. Go and read the CRAB criteria of the multiple myeloma, because so many times this question is there. Like C stands for the hypercalcemia, calcium. R stands for the renal dysfunction. A stands for the anemia. B stands for the bony lytic lesion. So that is the CRAB. So this is the homework for you. Again, go and get solve all the questions related to multiple myeloma. Again, I'm telling you, this is one of the most common malignancy in the world as far as the bone malignancy or hematopoietic malignancies are considered. And that's why this malignancy is very, very common to be asked in your exams. Even they usually ask that which is the most important prognostic markers in the multiple myeloma cases. Again, I'm giving you one thing, that is beta 2 microglobulin. This question is very commonly asked. Beta 2 microglobulin levels are very important for multiple myeloma prognosis. More will be the levels, bad will be the prognosis. So beta 2 microglobulin. Again, one more question. Beta 2 microglobulin. So this is about the multiple myeloma. Let's see the next question. So I have summarized all the important things in this session for you. All the important things, because the pathology, the medicine is very vast. Okay, and nowadays there is a no clear demarcation between the questions from the pathology, from the medicine. Okay, so you will get the questions from the different disciplines in the same question. In the same question, you will get the part of the medicine, part of the pathology, part of the pharma. They will ask the question from the medicine. Okay, finally the question answer will be from the pathology. They can ask you the question from the pathology and answer belongs to the pharma. So that these kind of questions are there in your exam. So you have to be very much aware about the pattern of the questions which are there in your exams recently. Okay, let's see the next question. Question number 6. A 4-year-old child presents with the development of the fever. The fever is there. The petechial spots are the rashes are there. there is a complaint of the fatigue also. The patient is having the pallor, that is anemia. What is pallor? Pallor means patient is having the anemia. So there is an anemia, that is the clue to you. Anemia associated with hepatosplenomegaly. Not the all anemias are associated with the hepatosplenomegaly. What are the anemias that are associated with the hepatosplenomegaly? Anemias like hemolytic anemias. All the types of hemolytic anemias are associated with the hepatosplenomegaly with sternal tenderness. So very particular thing. Now sternal tenderness is given, that belongs to leukemia categories. So whenever sternal tenderness is given, then you think about the leukemia. So the clue is there that anemia is there, hepatosplenomegaly is given, and the last word is sternal tenderness, which is commonly seen in leukemia patient. Okay, so this is a case of leukemia. Now what you have to answer, what is the clue here? The clue here again is the age is given to you, so you have to find out the leukemia which is commonly seen in children. Okay, so out of this, so the now this question becomes very simple because all the options belong to leukemia. Okay, even if you don't know that what is the answer, even then you can solve the question because all the options belong to leukemia. So that becomes a simple thing. If they will ask you that there is one option is of AML, one option is ALL, one third option is about the hemolytic anemia, option D is about some other type of anemia, then you must get confused that what could be the answer. But here the sternal tenderness is a great clue to you. The age is again a clue to you. Okay, so as far as the age is considered, which is the most common leukemia of the childhood? Answer is AL. Most common leukemia of the childhood is ALL. So this thing you have to remember. Most common leukemia in childhood is ALL. Even if they ask you the adolescence age group is there, and mediastinal mass is there. Mediastinal mass is there. Then which leukemia is there? Then that is T cell ALL, particularly common in that adolescence age group. Okay. Then which is the most common leukemia in adults? In adults, which is the most common leukemia? That is the CML. Most common leukemia in the adults is CML. Okay, AML can be seen in any age group. AML can be seen in the children, AML can be seen in the middle age, AML can be seen in the old age. Okay, but the question is that most common. Okay, so whenever question is given to you and the age is given to you, the only clue is age and nothing else is given. No blast, no type of the blast, no spatial stain is given to you, no immunohistochemical markers are given to you, no CD markers are given to you. Then you have to think about the age, in which age the common leukemias are there. So like in childhood the most common leukemia is ALL. In adult age group, which is the most common leukemia, that is the CML. So answer is very simple. It's a very simple question. They cannot make more simpler question than this thing. What type of complicated questions can be there belonging to the leukemia category? Complicated question when they will give you the the clinical picture and they will be giving you the hematology, like they are giving you the CBC finding, they are giving you the peripheral blood finding, they are giving you the number of the blast, the percentage of the blast. Then question become complicated. Like if they will give you that there are 30% blast, 30% blast in marrow and 2% blast in blood, what will be your diagnosis? They are giving you any age group, any number of the leukocytes are there, platelet is given, hemoglobin is given, all the things are given. But I am again telling you the clue always lie in the blast. Okay, whenever in hematology questions are given to you based on the leukemia lymphoma and the blast word is used, please be very much focused. If the blast number is more than 20%, if the blast number is more than 20%, where? In bone marrow. In bone marrow. Your answer would be there. Only in this single word, your answer would be there. Again, I'm telling you, please be very much focused. If the question is a huge question, Okay, the single paper is flooded with the same question. The age is given to you, like there is a 4-year-old male child who is having hepatomegaly, splenomegaly, anemia is there, thrombocytopenia is there, there is a the WBC count of 1 lakh is there, okay, neutrophilia is there, this is there, petechial rashes are there, patient is bleeding from the anus, patient is having the gum hypertrophy. So many findings are given to you to confuse you. And in one of the line they are saying that there is presence of 30% blast in bone marrow. Then forget everything. Okay, remove every line of the question from your brain and be focused. If more than 20% blast are given in the bone marrow, your answer would be acute leukemia. It is a thumb rule. Always remember, if the bone marrow is having more than 20% blast, then forget about everything. No age is important, no sex is important, no sign is important, no symptom is important, no RBC count is important, no WBC count is important, no platelet count is important. Everything will be not specific. Only one thing which is important here, blast percentage. Whenever blasts are more than 20%, again, I am repeating the same thing. If blasts are more than 20% in bone marrow, not the blood. In bone marrow, if the blasts are more than 20%, your answer is there. The answer is acute leukemia. Don't get confused. Okay, like in this question, they're asking that more than 30% blasts are there. That means they are more than 20%. Where? In marrow. Your answer is still is there. The answer is acute leukemia. Don't see the blast in the blood. That's not needed. Okay. So if bone marrow is having more than 20% blast, the answer is acute leukemia. If peripheral blood is having more than 20% blast, then what would be happening? Again, the answer is acute leukemia. Why? Because the peripheral blood are getting blast from the bone marrow only. If the peripheral blood is having more than 20% blast, then there is no possibility that the bone marrow will be having less than 20% blast. Because the factory of the blast is what? The bone marrow itself. So whenever the peripheral blood is having more than 20% blast, even if they are not giving you the bone marrow blast, then don't get confused, because bone marrow will be having more than 20% blast if the peripheral blood is having more than 20% blast. But the condition will be altering when peripheral blood has been given the less blast than 20%, but bone marrow is giving more than 20% blast. Then also the answer remains the same, the acute leukemia, because the diagnosis rests upon the bone marrow blast. Always. If the bone marrow is having more than 20% blast, it cannot be anything. It is always and always acute leukemia. If they are not giving you the bone marrow finding, they are just giving you the peripheral blood finding. If the peripheral blood is saying more than 20% blast, then you can assume that yes, the bone marrow must be having more than 20% blast, because if peripheral blood is having blasts that are coming from the bone marrow only. But sometimes there can be a problem, then the marrow is completely packed with the so many blasts that these blasts are not able to skip the bone marrow or not able to jump into the peripheral blood. So that's why in the peripheral blood, sometimes you are going to see few blasts, but in the bone marrow will be having more than 20% blast. Okay. So whenever these kind of questions are there, then acute leukemia should be in your mind. Okay. So that's my concept for the leukemias. So acute leukemia, the one liner is always a super hit question for you, that more than 20% blast in bone marrow and or peripheral blood. It can be there in the peripheral blood, it cannot be there in the peripheral blood. If it is there in the peripheral blood, then your answer remains the acute leukemia. In the peripheral blood, less than 20% blast are there, still patient can have the acute leukemia. Why? Because the bone marrow might have the more than 20% blast. Okay, so let's see the next question. A child presents to the OPD with the complaints of the fatigue, that is anemia. Most of the time, whenever anemia is given, the patient will be having the fatigue. Okay, on the further examination, anemia is there, like answer is given, anemia is there, with again hepatosplenomegaly. So anemia with hepatosplenomegaly, I told you again, what is the answer? Hemolytic anemia. This is one of the very common anemias where hepatosplenomegaly is the common finding. So, like, what are the hemolytic anemias in these options? Thalassemia is a hemolytic anemia. Yes, it's a hemolytic anemia. PNS, paroxysmal nocturnal hemoglobinuria. Is it a hemolytic anemia? Yes, it's also a hemolytic anemia. Anemia of chronic disease I can rule out because it's not a hemolytic anemia. Sickle cell anemia, yes, it's also a hemolytic anemia. Okay. And then how to solve? Let's see the peripheral blood smear of the question. This is the peripheral blood smear given to you, and you have to now see, is there any specific cell that belongs to these hemolytic anemia which are given in your options? Like thalassemia major is hemolytic anemia, PNH is hemolytic anemia, and sickle cell is a hemolytic anemia. Thalassemia major, what peripheral blood film you can get? You can see the targets RBC. That is particularly common in these cases. Sickle cell anemia, you will get the sickled cell. In PNH, what kind of cells? There are no particular cells which are commonly seen in PNH. Okay. Okay. So here you can see target cells, target RBC. Okay, here also target RBC is given to you. So is it a thalassemia? Target cells are given, but still it's not a thalassemia because here the biggest clue is these cells. What are these cells? These are the sickle cells. These are the sickle cells. So always remember, target cells can be seen not only in the thalassemia, target cells can be seen in any other hemolytic anemia like sickle cell anemia, another kind of hemoglobinopathies. So please remember, you have to be very much focused. Even when target cells are given to you, you have to focus, is there any other specific cell? Okay. So here the specific cells are the sickle cells. Your answer is sickle cell anemia. So that's how questions will be there. That's how the clues are there. That's how you have to solve the questions in hematology. There, hematology is very, very important for your exams. Why? Because almost every year you will get 10 to 12 questions around. Sometimes it can even reach up to the 15th question. So hematology is not the topic here in the pathology or in the medicine. Hematology become the subject now. Hematology itself is a subject. So please be very careful while reading the pathology. One of the most important part of the pathology is hematology itself. So because hematology is not the topic now, hematology is itself a subject. So you have to solve so many questions of the hematology, and very you have to be conceptual in the hematology because hematology is very mathematical. Okay, in hematology concepts are there. If you follow the concepts, then the question become very easy. If you're not going to follow the concept, then hematology is the most complicated thing in the whole medicine. Okay, let's see the next question. The image below shows origin from which of the following cell? It's a simple question. You have to see the picture. You have to get the answers from the picture only. No clue is being given to you in the question. That means that picture has to be very, very characteristic. So don't get disheartened in your exam because so many students say that the pictures are there and we are not able to make out that what the picture says. The pictures are not complicated. If the picture is directly given to you without any clue, that means that picture is having a characteristic finding that you have to see. Okay, like this picture. This picture is given to you, and they want to ask that this picture, with the cells which are given in this picture, the arrow is pointing towards the cell. What are those cells, and what is the origin of the cells? You can see here in the magnification. You can see here there is a cell which is having the mirror image nuclei, nuclei with a centrally placed prominent nucleoli. What are they? These are the nucleoli. Nucleoli. They are not the nucleus. There are two nucleus, but every nucleus in the center are having the prominent eosinophilic nucleoli. Eosinophilic means pink color nucleoli. That is itself a self-explanatory about the cell, that these are the RS cells. Reed Sternberg cells. Reed Sternberg cells, the malignant cells of the condition called as Hodgkin lymphoma. The Hodgkin's lymphoma. Now the question is, what is the origin of these cells? These RS cells are the malignant cells, but the question is again indirectly asking you. They are not giving the RS cells. So even when this question was there in the exam, so many students got the wrong answer because they got the answer that these are the RS cells, but they were not able to answer the question that what is the origin of these cells. Always remember, RS cells are the B lymphoid cells. Even If the question become more complicated, if you remember that they are the mature B lymphoid cells, they are not immature B lymphoid cells. So what is the origin of the Hodgkin's lymphoma? The Hodgkin originates from the mature B lymphoid cells of the germinal center. So that's the exact answer that you must be knowing before going for the exam as far as Hodgkin is considered. Hodgkin lymphoma is, again, I'm telling you, one of the most common lymphoma to be asked in your exams. RS cells or their tumor markers or their morphology is the most common CD markers that are ever asked in your exam. So what is the CD marker of the RS cells? The answer is CD15 positive, CD30 positive. So which is the tumor which is the CD15 and CD30 positive? The answer is Hodgkin's lymphoma. RS cells are positive for which type of CD markers? CD15 and CD30. Okay, so I'm very much clear about this thing. RS cells belongs to malignant cells of the Hodgkin's lymphoma. Hodgkin's lymphoma is one of the very common lymphoma to be asked in your exams. Next question, which is the most common infection associated with the Hodgkin's lymphoma? EBV, Epstein-Barr virus infection. So these are the important questions. Question number 1, which is the malignant cells of the Hodgkin's lymphoma? RS cells. Question number 2, which cells give origin to the RS cells? Mature B lymphoid cells. Which is the most common infection associated with the Hodgkin's lymphoma? EBV infection. What is the characteristic tumor markers of the Hodgkin's lymphoma? CD15 and CD30 positivity. Okay, what is the characteristic of the RS cells? That they are binucleate cells. They are binucleate cells. They are the binucleate cells which are having the owl eye appearance. Owl eye appearance. They are having the owl eye appearance. I think this is important about the all the important questions you must be knowing about the Hodgkin's. Let's see the next question. A 55-year-old patient presents with the difficulty in the breathing and rashes after the ingestion of the seafood. So what is the clue here is patient reduces the symptoms after eating the seafood. Whenever food is given to you, any kind of food like the peanuts are given to you or the seafood is given to you, some oil is given to you, that means they want to ask some kind of allergic response. Allergic response is there. Okay, and he has shown the similar reaction in the past also, means similar kind of history is repeated every time when the patient is eating that food or that oil or some kind of pollen grain is given to you or some kind of the scene is given to you, like the patient whenever enters the fields or the uh, any kind of farmhouse, the patient usually develop the sneezing, bout of the sneezing or the breathlessness is there. Those all sign and symptoms which are produced rapidly, suddenly produced after the exposure of any kind of antigen, that means they want to ask you about the allergic response. Okay, so what type of allergies are having the hypersensitivity? The answer is type 1. Always the answer remains always the same. All the allergies belongs to type 1 hypersensitivity reaction that are called as immediate hypersensitivity reaction. Why they are called as immediate? Why the symptoms are produced immediate? Because of the mast cells released histamine at the same time when the event is going on, because mast cells are not going to produce the histamine when the event is there. Mast cells are already having the pre-formed histamine in their cytoplasm. So whenever event is there, antigen is exposed again to the same individual, the histamine will be released at the same time. Within the few minutes the histamine will be gushed into our blood and patient is going to develop the sign and symptoms. What histamine is going to do? Histamine is going to produce the bronchospasm. There will be a breathlessness. Histamine can produce the rashes. Histamine can produce the itching. Histamine can produce the sudden vasodilation. The patient can be going into the shock-like condition. So that is called as anaphylactic shock also. So anaphylaxis is also belongs to which category? Type 1 hypersensitivity reaction. Okay, so I'm clear about this thing that type 1 hypersensitivity means immediate hypersensitivity. Which is the most important biochemical marker for type 1 hypersensitivity? That is the histamine. Most important cells belongs to mast cell category. what are the types or what are the causes of the type 1 hypersensitivity reaction, all the types of allergies, all the type of anaphylactic shock, like allergic, like hay fever. Okay, hay fever is the allergic response. Urticaria is the allergic response. Okay, asthma is the allergic response. Atopy is the allergic response, like atopic dermatitis. Okay, anaphylactic shock is a allergic response, sudden episode. Okay, type 2 hypersensitivity belongs to antibody mediated diseases. Antibody mediated diseases are belongs to type 2 category. Antibody, purely antibody, not immune complex. Please remember, immune complex belongs to type 3. Immune complex belongs to type 3 category. And type 4, you have to remember, in form of granulomatous condition. All the granulomatous condition belongs to type 4 category. So it's a very simple. How you are going to remember all the different types? Just remember the basics. Type 1 belongs to allergic response. Type 2 belongs to antibody mediated conditions. Type 3 belongs to immune complex mediated condition. Type 4 belongs to granulomatous condition. Type 4 like tuberculosis, leprosy, contact dermatitis. All these are the granulomatous condition like Crohn's disease, sarcoidosis. Any kind of granulomatous condition will be categorized into type 4 hypersensitivity. All the types of immune complex reactions or immune complex diseases belongs to type 3, like all the types of autoimmune disease like SLE, rheumatoid arthritis, Sjogren's syndrome, okay, arthritis reaction, serum sickness, all belongs to type 3 category. Type 2 means antibody. So there are very few antibody mediated diseases. There are not too many diseases in the medicine that belongs to the antibody mediated conditions. So what are the antibody mediated conditions? Like antibody mediated conditions. Antibody mediated conditions like good pasture of kidney. Okay. Myasthenia gravis. Myasthenia gravis. Okay. Guillain-Barré syndrome, GBS, Guillain-Barré syndrome. So these are the few things which you have to keep in your mind. Okay. So it was lagging. So now it's all right. So good pasture, myasthenia, GBS, even one of the very important disease that is belongs to thyroid, that is Graves disease. Graves disease. That is also an antibody mediated disease. Okay. So now these two diseases, myasthenia and Graves disease, has also been categorized into type 5 hypersensitivity reaction. So that is nowadays newer question, that what is the type 5 hypersensitivity reaction. So there are two conditions, that are myasthenia gravis and Graves disease, that belongs to the antibody mediated condition also earlier, but nowadays they have been categorized into type 5 category also. Question number 10. Based on the given peripheral blood smear, which of the following is your most likely diagnosis? So let's see the peripheral blood smear. So very important. So many clues are given to you. Like in this first clue, the RBC is there. In RBC, you can see there is a nucleus also. That is called as nucleated RBCs. Okay. So in this picture also, you can see the nucleated RBCs. In this third picture, you can see the target cells. Like these, RBC will be there, and you are going to see the target RBC. So I think now I am very much clear that the peripheral blood is giving you the two important clues, that the nucleated RBCs are there and target RBCs they are there. So let's see the options. So two clues are there, NRBC, that is nucleated RBC, and target RBC. I told you that these target RBCs are commonly seen in which condition? Thalassemias or hemolytic anemia. Let's see, is there any option belonging to this category? Yes, option B belongs to this category, thalassemia major. So patient of the thalassemia major will be having the nucleated RBCs also and the targeted RBCs also. IDA, there will be no NRBC, there cannot be a target RBC. Myelofibrosis, yes, you can see the NRBCs are there. Okay, but with myelofibrosis, NRBC, you are going to see one particular RBCs that are called as teardrop RBC. That is commonly seen in myelofibrosis, not the target cells. So Myelofibrosis will give you the target, not target RBC, the teardrop RBC. So if question is like this, that NRBC is nucleated RBCs and teardrop RBCs are given, then what is your answer? Then you will say myelofibrosis can be the one of the options. Myelodysplastic syndrome, there is MDS, myelodysplasia will be there. So dysplastic cells are there. What is the dysplastic cells in the peripheral blood that you can very clearly appreciate? I'm giving you again the clue that these kind of neutrophils will be there that are bilobed. Usually neutrophils are trilobed. At least three lobes should be there for calling it as a normal neutrophil. But here there are bilobed neutrophils which will be seen in myelodysplastic syndrome cases. Bilobed neutrophils. That is a clue for you. Bilobed neutrophils. Why? What bilobed neutrophils are called as? They are having a special name that is called as pseudo-Pelger Hue cells. Pseudo-Pelger Hue cells. Okay, so bilobe neutrophil, whenever they are given to you in the options or in the picture, you have to find out the answer will be MDS, myelodysplastic syndrome. In the bone marrow, there are so many cells which can show the dysplasia, but I'm not going into the details. So you have to remember, this is the homework again for you. What are the dysplastic cells in the marrow? Okay, what are the pond ball megakaryocytes? What are the micro megakaryocytes? Okay, what are the ring sideroblasts? Okay, so all these are the dysplastic cells. Okay, a 60-year-old male present with the low backache, X-ray of the lumbosacral spine shows the osteoblastic changes. Here the answer is very, very specific. Why? Because osteoclastic or osteolysis can be there in most of the metastases belonging to the bone. But here is osteoblastic. Osteoblastic means bone forming. Okay, so bone producing metastases are very, very rare. So there is only one condition that can produce the osteoblastic activity when it is metastasizing to bone, that is the carcinoma prostate. Otherwise, all the other conditions, renal cell carcinoma, multiple myeloma, port spine, they all leads to osteolysis. So this is a very simple thing, but it has been asked in your exam. That's why I'm telling you. So carcinoma prostate belongs to one of the malignancy which metastasizes to bone very commonly, but it is not going to produce the lysis of the bone. It is going to produce the osteoblastic activity in the bone. So that's why it's so particularly important. Okay. Last question. A child presents with the difficulty in the eating due to the jaw swelling. Enlarged cervical lymph nodes are there. Lymph node biopsy is given to you. So let's see the lymph node biopsy. So first thing is the age is a childhood age. The sign is the jaw swelling is there. Enlarged cervical lymph nodes and cervical lymph node biopsy is given to you. This is the biopsy picture. I think it's a particularly very common lymph node biopsy that is given to you in your exams. You can see the whole blue color appearance of the lymph node. Everywhere you can see the blue color. Why? Because all the cells are having the nucleus, the big nucleus, and the cytoplasm is very scanty. Cytoplasm is scanty, so that's why you are going to see only and only the blue colored nucleus. But in some cells you can see the cytoplasm is there, like in these cells you can see here there is a clear cytoplasm. There is a clear cytoplasm in these bigger cells. What are these bigger cells? These are the macrophages. So these bigger cells are the macrophages, which are appearing like a stars, in this blue color sky. So sky is made up of these blue color cells, which are actually the malignant cells of the this lymph node. And in between these blue color cells, you can see there are some large cells which are having the good amount of the cytoplasm, which is the cleared in its color. So that's why they are behaving or looking like a resembling like stars. So this is called as starry sky appearance. Starry sky appearance on bone marrow, sorry, on lymph node biopsy. Stars are macrophages. Sky is the malignant cell itself. And this is particularly common in which thing? I think everybody knows that its answer is Burkitt's lymphoma. Okay. Hodgkin cell, what they will be giving you? RS cells. infectious mononucleosis, what they will be giving you the atypical lymphocytes, or that are called as downy cells. Downey, downy cells. Kikuchi disease belongs to necrotizing necrotizing lymphadenitis. That means they will be giving you the necrosis in the smear. And the answer belongs to Burkitt's because it's so straightforward. It's so particularly that much characteristic that you cannot miss out this picture in your exams. So I think this is sufficient for this session. Again, I will be recollecting certain more important question, and I'll get back to you with some important question. Thank you for listening. Mahesh, hello, Mahesh. Hmm. हेलो हेलो हाँ हाँ, हो गया, बंद करो, रिकॉर्ड हो गया। रिकॉर्डिंग एक सेकंड में करती सर, एक सेकंड। इस पे लिखा होता आ रहा है ऊपर, रिकॉर्डिंग क्या करना है? एक सेकंड।